These guys keep making spelling mistakes. It's Consia.
Consia.
Yeah, not Conica.
Okay, it is just gone after 10 o'clock, our start time. And if we can take a sit and settle down, then we can make a start. Really good to have your company this morning. As my nameplate says, I'm Keshan Sheth, and I will be chairing this morning's meeting from this hugely impressive location. Good to be back in Hounslow. I say hugely impressive, and it is hugely impressive. And we have our friend, the Chief Executive of Hounslow Council, with us this morning to welcome the committee. And thank you very much, Nal, for taking the time out to join us this morning to welcome. I know you're busy. I know you have just come from another meeting that you are chairing to be with us to warmly welcome. So really good to have you join us very briefly. So over to you, please.
Thank you very much, Councillor Sheth. And I'd like to say welcome to all members of the Joint Health Overview and Scrutiny Committee to Hounslow House, which is the headquarters of Hounslow Council, and we're delighted to have you here. You've got a really full agenda, as Councillor Sheth has already indicated. I've just come out of a meeting where I'm chairing about the budget for next year, so I better go back. But I wanted to come and say it's extraordinarily important to us in Hounslow that health and care services are fully recognised and overseen by our members. And I'm delighted that Councillor Marina Sharma is here as a member of this committee in order to give that assurance to the rest of the council. Hounslow is very ambitious in relation to health and care, and particularly in relation to health and care integration. I chair the borough-based partnership on behalf of members, and we have a good, solid partnership with local health providers locally. And we are working jointly now in relation to an integration programme, which has been supported by external support advisors in order that we can come up with a plan about further and deeper integration of health and care in the borough. Now, that's not without its problems or issues, and no system is perfect, but there's a willingness for all of us to work collectively and together in order that we deliver better outcomes for our residents, and making sure that we make sure that all of the resources, that almost £500 million of funding that goes into health and care in the borough is deployed effectively and represents value for money for taxpayers, but also effectively delivers positive outcomes for our residents. So that process will continue and will be subject to further examination by our members through Cabinet, through our scrutiny process, and also through this committee in due course, since a lot of the services which are provided in the borough are shared with others, and in one instance, in a different ICS as well. So we will be, if you will, Councillor Sheth, be bringing forward propositions in due course with this committee to consider the further deeper integration of health and care within Hounslow, particularly in the context of Hounslow and Richmond Community Health Services, which obviously is shared with Richmond. And I'm really delighted that Councillor Volham is here, and also involves Kingston Hospital Foundation Trust, which is, as you know, in the South West London ICS, which is not the one in which we are located today. So all of that complexity hopefully will be resolved in due course, but we will subject that, as we're obliged to do and as we willingly want to do, to further exposure to you as members of this committee and our own scrutiny processes. I'll finish there because you've got quite a full agenda here, and there's some really fascinating things which we're involved with directly and intimately as well. I'll finish by saying I'm also delighted to be able to be the co-chair the Health Equity Board for North West London ICB, and I would really be delighted to be invited by your committee to look at how we are dealing with health inequality across North West London in due course, if you wish to hear from me as the chair. And Rob obviously is nodding sagely there. Thank you very much, Chair.
Thank you very much. We would be delighted to have your company as always now. It goes without saying. And talking about health equity, indeed, we were really, I particularly was very heartened to hear your contribution not that long ago at Hammersmith, where you presented and did piece of work throughout the day in a very, very engaging way. So thank you very much for all your work, not just here in Hounslow, but right across the Northwest London geography on behalf of the local government. Thank you very much indeed for joining us this morning. Thank you. Marina and Yusuf and the other colleagues who are here from Hounslow, a big thank you for arranging our visit this morning. Grateful to you. Marina, I don't know whether you want to say a quick hello. If you do, then here is the opportunity.
Thank you, Chair. Yes, I'd just like to welcome you all to our lovely Hounslow house.
Thank you very much indeed. Thank you. So let's then start our first item first then. You should have your papers either in front of you or electronically. So I'm going to take apologies first then, please. Apologies, Jyoti?
None that I've received.
Thank you. Declarations of interest. So there is a guide at the start of our papers to assist us. So let me start with my declaration first, and then I'll take any other declarations. So I'm the lead governor of Central and Northwest London NHS Foundation Trust. Ben, please.
I am employed by the Nursing and Midwifery Council.
Thank you, Ben. Marina, please.
I work for a local domiciliary care provider.
Thank you. Any other declarations? Yes.
I'm employed
Claire.
by Hounslow and Richmond Community Healthcare Trust.
Thank you very much for that, Claire. So we'll now move to the minutes of our last meeting, which was held at Kensington Town Hall. And my thanks and appreciations to the colleagues at Kensington for producing these minutes for us. Are there any issues that we would like to air as far as the minutes are concerned? Otherwise, we'll take it as tabled. Thank you. Any matters arising which is not covered elsewhere? Thank you. So then we come to the first substantive paper, which is the ICS Workforce Strategy and Program Update. And we have a number of colleagues with us this morning. Claire Murdoch, who is no stranger to this committee, but I think Nina is joining us for the very first time. So very good morning to you and good to have your company. So Claire, over to you. So we do have the paper in front of us with those very glossy slides. But if you want to spend next few minutes just to giving us the key highlights, please.
Thank you very much, Chair, and good morning to everybody. And huge apologies I can't be there in person. It's a very back-to-back day today, I'm afraid. Really briefly, because I'd like to hand over to my colleague Nina. I'm the SRO for Workforce in North West London. I guess all SROs would say this, but I think our workforce really has to be our top priority other than our patients, insofar as they're the lifeblood of what we do in North West London. We have widely discussed our workforce strategy with a whole range of colleagues. We have absolutely tried to bring it to life so it's uniquely North West London, and in particular tried to very much focus on the opportunities of routes into employment, our role as an anchor organisation, looking really creatively at how we can employ local people from different backgrounds, create career and job opportunities, reflect our local communities, and be more flexible than we've ever been before. Apprenticeship routes are a good example, but they're not the only example of how we'd like to create more homegrown workforce. We've absolutely worked with local authority colleagues on this as well, and there are some things such as the Health and Care Academy where we would really appreciate colleagues' feedback and input as we try and grow something that supports an integrated approach to workforce. We do think North West London is uniquely vibrant and diverse, and our workforce should reflect that. A big focus as well on retention. it's all very well thinking about bringing people up to work in the health and care sector, but we need to retain them. More detail on that in the slides. And the last thing I would say before handing over to Nina is that our workforce strategy and plan and action needs to sit in support of real transformation in patient care, whether that's the incorporation of digital technologies and assistive technologies, whether it's redesigning pathways of care to make sure we're really optimising every penny and the health and care benefits and outcomes. So it needs to stay really regularly reviewed, and the strategy and plan, and sit in support of all of those things. But I really like, and we've done a lot of work, and really appreciate the feedback from this committee. But I'd like to just very briefly hand over to Nina, who can just give you one or two more granular examples of how we're thinking. Thank you, Chair.
Thank you for that, Claire. So, Nina, I think you're coming for the first time to this committee. It'd be really good to have a brief introduction from you before you supplement what we have just heard from Claire Murdoch this morning, please.
I'm Nina Singh, and I'm the Chief People Officer for West London, but also the co-lead for the ICS, along with my job share partner, Kevin Croft. So he and I have been he's a CPO at Imperial. So between
CPO meaning Chief People Officer.
Chief People Officer at Imperial. So between us, we cover all the different services within the health service. So we've got acute, which is represented by Kevin. I represent mental health and community. And we think by working together in this way is a really unique opportunity to be truly integrated in the way that we plan and deliver workforce initiatives. So to supplement what Claire has just said, in developing the workforce strategy, I think last time Claire was here, the strategy was in development and we had our 2 high-level themes. Since then, we've been working on how we operationalise those themes into 7 workforce priorities. Now, they're shown on slide 2. Our chief execs were really keen that we work on 7 because those are our must-dos and it covers all the agenda that Claire has just outlined, but really focus our attention in the next 18 months on the top 3 priorities. And in my slides, that's shown on slide 6. So in your pack, I don't know what number it has, but we have tried to show on slide 6 the interconnection between the top 3 priorities and the remaining 4 priorities. And I would say in terms of priority, that the priorities were development in discussion with the partner organisations in North West London, including our colleagues at local authority. What we've tried to do is be really clear and be very precise about what exactly we will deliver, and that's shown on slide 7. So rather than just kind of being, I think workforces can be intangible sometimes. So we've tried to be really precise about what we will deliver. And we've tried to be precise about what we will deliver at system level, what will be delivered by provider collaborations, and what will be delivered by individual organisation. And our focus has been very much working at system level with our local authority colleagues and with our NHS colleagues. And so Claire has already gone through the top 3 priorities, so I won't describe them in any more detail than that. The one she didn't touch on was the one around multi-professional education and training strategy. We don't have one for North West London yet. We think that's a real opportunity for us. We know in the NHS long-term plan, there is additional investment coming through, and we need to be better positioned in order to benefit from that investment and make sure it supports the training places that we need in North West London. So that's kind of the 3rd strand of our priorities that we'll be looking at the next 18 months. And beyond that, I think Claire has already covered all the other key points that I would want to raise. Rob, I don't know if you want to say anything.
Thank you, Rob, and good to have your company this morning. Thank you. Thank you, Nina, and thank you, Claire. All right. So, unsurprisingly, There'll be some questions now from my colleague. And let me bring Nick in first. Nick, good to see you. Good morning.
Yeah, good to be here and very good to be in Hounslow. I've got a question around the statement on page 4 of the pack under recruitment opportunities. It says there is a significant refugee community in Northwest London, a potential recruitment pipeline. Obviously, being in Hillingdon Heathrow Airport, you know, we do have a significant refugee community in our area, and I think it's really good to see that, you know, we're going to be able to engage them in a really positive way. But I just want to find out more about how you might do that, because my understanding is working for asylum seekers is a bit difficult. So how are you going to actually turn that into reality?
So
Thank you, Nick. Nina, please.
So it has been particularly challenging, and what we've brought together is a collection of partner organisations, but we're also working with the Refugee Council and voluntary groups that specialise in working with the refugee community. And rather than beaver away in our own individual organisations, what we've worked out is a pathway, particularly around the immigration and visa applications. And the particular challenge that refugee community face is how do they get a DBS check? And this, which is one of the pre-employment checks for the NHS. Now, this seems like a really straightforward issue, but if you haven't been in the country that long, it's really hard to pass that. And if you can't pass go at that level, you can't get a job within the NHS. So we've worked through a pathway that will enable us to do that. We've shared learning across our partner organisations, so we don't have to reinvent the wheel every single time. And to date, we have been able to recruit 62 people, refugees, within our organisations, of which 11 have been doctors who have gone into either a medical role or a medical support worker role.
So how are we working with the mayor's team to advance this further, please?
So we're working with the Mayor's Office in terms of the Anchors programme, and the refugee recruitment programme we've got sits as part of the Anchor projects. So it's all interlinked through the overarching Anchors programme that we've got. So we get representation from the Mayor's group through that forum. Thank
you, Nick. Thank you very much. So let me bring Marina, please. Marina, thank you.
Hi, thank you, Chair. So my question is that sort of almost half of all new nurses in 2022-23 were educated overseas, and a small but growing proportion are from the red list countries, those which are facing their own shortage of healthcare staff. Can you provide insights at all into any measures in place to ensure our recruitment is ethical when hiring overseas nurses?
So the NHS has a code of practice of where it can recruit from, and we work very much to that code of practice list. So if there is a country that's on the red list, we cannot recruit from there, and we don't encourage our organisations to recruit from there. The list changes regularly, and the type of people you can recruit for the different streams of nursing, whether it's mental health or as an RGN, so the countries will vary for each of those streams. So we work within the NHS code of practice.
Thank you. Let me bring Natalia in, who wants to take you back to the first reply. Natalia, please.
Thank you very much, Chair. Thank you very much. I've got a question about yesterday's announcement. So there were some announcements on changes to immigration rules. Will this affect the ICS workforce strategy and program?
Sorry, I missed the announcement yesterday. If you could just explain what it is.
Well, the announcement's putting very strict restrictions in terms of carers and health workers as well.
So
Claire is nodding her head. Maybe, Claire, if you want to start off the reply, and then I'll bring Nina in.
Thank you so much. I mean, we haven't yet had the opportunity to properly assess the announcements that were made in Parliament yesterday about the new thresholds, both for salary, but also for bringing family members into the country. It's really important that we do that work together with our health and care colleagues, because I am concerned that potentially the financial thresholds and the ability or the restrictions on bringing family members in may see a resultant drop-off in people who want to work in the care sector or are willing to, and in the health sector. But I think it would be fair to say we need to do a detailed assessment of what we think that could mean.
I know it's very early, but perhaps there may well have to be some mitigating situations placed in, and we would be grateful if you could please keep this committee updated as those conversations unfold. Nina and Rob, please. Nina.
Just to add to that, there is a group called NHS employers, and all of the NHS employers, as it says on the tin, work together. We have a really good connection now through NHS employers with the immigration department, and we will be working with them through NHS employers to make sure that we can still recruit to our shortage occupations and we're not impacted. Despite what you read in the papers, in the last few years, I would say in the last 5 years, we have had a really good relationship through NHS employers with the immigration department, and the NHS has been able to recruit, and we would want to capitalise on that with a recent announcement and make sure the assurances are still in place.
Yes, thank you for that. Natalia, please.
No, thank you very much. I know that the announcement was only done yesterday, but it's good to know that that system's already in place and there's been success from the example that you gave, and also that you'll be assessing as well the situation going forward. So thank you very much.
Thank you. And let me bring my colleague on screen from Westminster, Councillor Albert. Very welcome to this committee. She is the new colleague. And looking forward to having your contribution, not just this morning, but in coming weeks. Thank you, Consia.
Thank you. Yes, so the workforce strategy and programme, it outlines the new ways of working to support new models of care, but this doesn't include mental health as a known priority. When it has been noted previously, there were significant gaps in specialist mental health care. This is also alongside the intended provisions for additional mental health care to be carried out in the community. And there is a significant need, especially in light of the closure of the Gordon Hospital. With this in mind, what is being done to address this issue, and why isn't mental health highlighted in the report as a priority?
Thank you for that. Claire is not just SRO for workforce, but she's also the national director. So let me bring Claire to answer, and then I'll bring Nina in the room. Claire,
Yes,
please.
Thank you. Thank you so much. And yes, I should declare that I'm also the National Director for Mental Health in England. And workforce growth in mental health is an absolutely key part of the ICS's plans. We can see a clear history of recent investment in mental health across the 8 boroughs. That's the Mental Health Investment Standard money is ring-fenced by government and the NHS. We understand that ring-fence of investment is going to continue into next year, 24-25, and possibly, if I have anything to do with it, beyond that. Virtually all of that ring-fenced investment translates into workforce, and so mental health absolutely is a priority, and I would suggest that we should perhaps take that away back to these slides and make sure it's prominently there. We can see growth in workforce, but more is required to, as you say, deliver our plans. But I don't know if Rob, as Chief Executive of the ICS, wants to give assurance around the commitment that mental health is a key priority.
Thank you, Claire. Rob?
Absolutely. I mean, I think what's underneath all of these headlines and these glossy slides is a significant growth in workforce in mental health, in primary care and in our hospitals. And the key issue is, and as this strategy is laying out, is are we making best use of those staff? Are we opening up the avenues of employment to all of our communities and opportunities that we have out there, and we're breaking down the barriers? So absolutely, mental health is fundamental to the strategy, how we get the workforce to support the new ways of working in mental health. It's great to have the national director on the patch. We have our national, we have our work ongoing on our mental health strategy, and indeed working with our our trusts, of which Nina is the Chief People Officer of one of our two major mental health providers on the patch, I'm sure they'll make sure that we don't lose our focus as a system on the importance of mental health workforce.
Thank you for that. Consuelo, do you want to come back with another point?
Yes, firstly, I want to say thank you. Thank you for taking that away and for looking at it more closely and being able to add that as a priority. That would be really helpful, I think. Just secondly, and I think what you just said may already cover some of this, but just to be certain, on page 26, it highlights that the demand for mental health services is increasing and delays in discharging patients from a hospital bed to a community setting remains a major focus. This will require additional workforce, but it does sound as if you are already thinking of that as a way forward. And so just to have you, confirm that.
So both, Claire, you may
Yes.
not be able to see, but Rob and Nina are both nodding in affirmative. I think so is Pipa. But let me bring you in very quickly, Claire, for a brief reply.
So very quickly, we have immense pressure on our, we call it the UEC pathway, but the urgent and emergency care pathway. And, at its most simple, you're only admitting people if you're discharging people. We're seeing when they're ready for discharge. These are vital. The acute beds or inpatient beds are a vital and really important part of good mental health care. And we have seen a creeping increase in length of stay and delayed transfers of care. Indeed, yesterday with my own team at CMWL, we were talking about 38 delayed transfers of care. Poor care for the people involved, because when you're ready to leave hospital, you should leave hospital, and close work across health and care together to look at things like housing, supported packages of care, proper sufficient community mental health staff and others, routes into employment for those who are able, really enhanced discharge planning is an absolutely critical part of the modern mental health service, and therefore workforce and joint working. It's really, really important.
Thank you for that. Let me bring Chetna in, please. Chetna, good morning to you.
Good morning. Thank you, everybody. On your last slide on this item, you're talking about the program structure. Specifically, the paper states that sustained transformation, including redesigning roles and teams and staffing structures, is required to improve productivity. A few points on this. Can you clarify for the committee how productivity is being measured by Northwest London ICS? Also, can you expand on the role of the productivity tool that is being developed? And also, how is this going to be measured and reviewed? And, how can we keep an eye on this going forwards? Thank you.
Thank you for that, Chetna. Now, Claire, perhaps you can start, and then I'll bring the colleagues in the room. Thank you.
Yes, thank you. Just really, really briefly on this, it's absolutely vital that we understand productivity, and productivity is covers so much. It is everything from length of stay in hospital, for example, or delayed discharges we were talking about earlier. But it's also about making sure we're measuring that people are getting the right outcomes. It's about understanding what the waiting lists are and access to care and treatment by way of what we look at. So waiting and access. And of course it's about activity, but it can't be just for its own sake. This has to be high quality, meaningful activity. So there is more work in development around what should our productivity programme look like? How do we all agree what best in class looks like? And there's some really active examples of it in train, really great work streams, but we need now this year to pull that together into bespoke programmes that we can all have line of sight to.
Great.
So for example, on mental health, the ICS and my Chief Finance Officer, Tom Shearer, are currently looking at investment in each of the 8 boroughs for mental health and what you get for it, literally what you get for it. How many people are you seeing? What's the outcomes? Where are the service gaps? What do we do next? So a huge amount of work in train, but we do think we can take that to the next level.
Thank you. Very briefly, Chetna.
Very quickly, just to go back on more qualitative data, not just quantitative. I just want to make sure that that sort of data is also going to be measured, and in terms of productivity, not just numbers, stats and graphs. So the qualitative data The touchy-feely
Could I
stuff.
just say on, yeah, absolutely, and I started with outcomes, and I should have perhaps been a bit clearer that by outcome measurement, it has to be about patient experience, it has to be about measurable improvement in symptoms and functioning. We are, for example, at the moment just rolling out the PCREF. It's a nationally mandated structure, but it is about parent, patient and race equality and carer evaluation. What's your experience of service? What worked for you? What didn't? And so it's really fundamentally important that at the centre of anything we do on productivity,
Thank you.
we understand the impacts of anything that we do, both from a patient experience point of view, but also a clinical outcome and improvement point of view.
Great.
And I would say we need to do that with social care to look at the meaningful life and meaningful activities point of view as well. That has to be at the centre.
Great. Thank you for that. Rob, please.
The NHS historically has tended to be quite acute hospital focused in terms of its measurement of productivity and not taking due account to experience and outcomes data. As part of what I did nationally on the Getting It Right First Time programme, and indeed what Rory and the team have done on the involvement strategy, we need to bring insight data, experience data alongside the quantitative data. So we publish every month our insight data. We want to do more with local authority partners through borough-based partnerships on gathering that insight data and applying it to the experience data alongside the quantitative data. Second point, that North West London is probably further ahead than anyone in the country on trying to count what takes place out of hospital in community and mental health services in a standardized way, not because we're looking to disinvest, but because we're looking to invest. And to invest, one needs to understand what one gets for one's money in the first instance, and to uphold value for money and best value from that, to understand, and the work that Claire has described is, yes, looking at how we standardize, how we capture outcomes, count the data, work out what our workforce is doing in output terms, not because we're looking to cut things or streamline, but because that means the money that we are increasingly spending out of hospital, for example, in mental health services, we want to put at the most optimum place to get the best outcomes for patients with a limited and constrained workforce resource.
Great. Thank you very much indeed for that. Chetna, I'm going to move forward to Lucy. Lucy, good morning to you.
Morning. Thank you for having us, Hounslow. I just wanted to focus on maternity services. As of the 6,000 vacancies you talk about here, 39% are qualified nurses and midwives, which feels concerning. So what are the implications of patient safety as a result of these vacancies? And what is our strategy to turn these vacancy levels around? And is there a reason why nursing and midwifery are being particularly affected?
So we have Pippa Nightingale, again, no stranger to this committee. It's always a special joy to have your company. Good morning.
I haven't been to Hounslow for ages. I forgot how posh it is here, actually. So thanks for having us. So maternity is obviously really important. It's an important work stream. We know nationally when there's a shortage. We know the maternal reviews that have happened across the country. We certainly do not want to be in that position in North West London and don't expect to be. We've got a very ambitious plan for recruitment in midwifery. And actually, for the first time, we've got a pipeline that takes us to a less than 5% vacancy rate. We have started to recruit overseas, and that has brought some really experienced midwives actually into working in North West London. We're one of the first systems to do it. And we've now got 19 qualified overseas midwives who really do start to deliver a sort of diverse offer of midwifery as well, which is really helpful for the population we're providing care for. We've just recruited 54 midwives from Turkey last week, and we're going to Dubai next week, and we're recruiting for the system. We're not recruiting for a hospital in North West London, we're recruiting for the system. And we're recruiting another 54 midwives from Dubai next week, and then we're going to, I can't remember where, if I'm honest, somewhere else in January. That actually takes us to an almost fully recruited position, which would be the first time in a long time for North West London that we've been in that position. That means we've recruited to not only the vacant posts we've got, but the posts that our acuity data using a national acuity tool says we should have in best practice. So we're recruiting to higher levels we ever have done before. So it's a very positive position. We've also expanded our student training. So this shouldn't just be about overseas. That's almost a bit of a temporary fix. We need to sustain our home model as well. So we've increased our training numbers within North West London, and we've got the biggest amount of apprenticeship midwives we've ever had as well. Now that takes longer, but that for me is a better investment because you tend to recruit people locally that will work locally and stay with us for a long time. So we need to invest in all measures, and we've put our money in every pot really to make sure we've got a sustainable maternity plan.
Thank you, Lucy.
Thank you. That sounds really encouraging. The only question I'd follow up with is in terms of retention of the overseas people that you're bringing in. What's your sort of plan there? Just as,
So
but I
looking-
mean, yeah.
So looking
And not
at
just retention, but also training and continuous development.
Yeah, there's three things I think we need to focus on. So everyone focuses on retention of an overseas nurse or midwife. The retention is actually really positive for them. They tend to come and they stay. They have made a big life change decision and they come and stay with us. I'm probably more interested in their experience with us. So what does it feel like to be an overseas nurse or midwife, to come with us to this alien country that you don't know anybody? How are we looking after them? What's our support package? What's our housing package? What's our benefits package for them? That is quite a complex picture and we're doing lots of work on it. The other thing then is how do they progress in our NHS system? So you see a lot of our overseas nurses being stuck at a band 6 or some at a band 7, but actually why are they not progressing into the senior management roles? We've got many overseas, this is not a new thing, we've been doing this for many years. We've got many very experienced overseas nurses. So now we're doing some work around our inclusion agenda of how do we promote them? How do we make sure that their voices are heard, that they do have the right access to training and development and leadership development so they can progress alongside the rest of the workforce? So them two bits are probably more important than retention, actually.
Thank you for that. Let me bring Claire in. Claire, good morning.
I just wanted to raise on the priority expand and diversify routes into employment, that you've listed various things like 50 senior carers and that sort of thing. But I think one big barrier to employment is people with school-age children, particularly primary school children, who would be the sort of people who could do starter training that fits around term time and holidays and all of that. And by the time their children get secondary school, they could be fully trained and up and running. And I think at the moment it's extremely difficult. Even if there are apprentice schemes, it still is really hard to manage it.
Thank you, Claire.
So one of our key programs around retention is looking at the whole issue around flexible working. We've seen in our staff survey data for all of North West London, this is an area that we need to improve on, and giving people more control over their hours of work is one of the key things that we want to try and enable. And we're doing that in two ways. One, for those working in inpatient setting or in hospitals, it's through the team rostering approach, which the approach has been used at Royal Free to great benefit, and they've shown a massive reduction in their vacancy rate by improving opportunities for people to have more control over their working hours. The other part of that is not just having control over your hours, is actually flexible working and how we enable that. That is a much more difficult conversation. On the one hand, we've got increasing demand for services. We've got all these vacancy gaps. And if you're an operational manager, you have someone like me saying, you know, you should really think about flexible working. For them, they've got so many gaps on their roster. How do you then enable that? And my answer would be, by having flexible working, you're going to fill more gaps on your roster. But it is a difficult workforce planning discussion that we need to enable. And I think part of the transformational change is to shift the cultural thinking around flexible working, and that will take time. So we're doing first step, which is around control over working hours, whilst we concurrently work on the flexible working options within North West London.
And I just want to add in, I think also training programs, so that you get people in, you train them up during that period where they're not really free to fill up your roster at night and etc.
Agreed.
So I think it would be good to have a target specifically at parents with probably primary school age children.
Thank you for that, Claire. Natalia, please.
Thank you. So a quick question, please. And I welcome the reference to the Race Inequalities Steering Group. Could we please have just a quick update on what has been done in the last few months with the steering group and plans going forward? Thank you very much.
Thank you. Rob?
Very happy to keep it relatively brief, but provide further information as you wish. We can do an annual report on the work of the group and provide it to that committee. I chair it jointly with Linda Jackson. It has energetic participation from across the system, both local authority and health partners. It is bringing together the single version of the truth around race, workforce race equality standards, the reality of the lived experience of racism within the National Health Service, and bringing together initiatives that we're working on across the system. And we've seen a large number of really good examples of working with local communities, reaching out into communities and understanding how each of our service offerings are being amended and taking account of race disparity in terms of both access to and outcomes from health and care services, but also a big focus on workforce and as I say, the workforce race equality standard, how we're going to work with across local authorities and NHS institutions, and ensuring that all of our health equality impact assessments are not just pieces of paper. They are real initiatives based on talking to real people and with the lived experience in health and care services. So in its first year, it's done some quite exciting action-focused things, which I'm happy to bring back some insight into it. It has not been a talking shop, which was my main concern when we started, but a year in, there's some really good outcomes coming as a result of the work of the North West London Race Equality Group.
Thank you. And what would be helpful for this particular committee, by way of assurance, Nina mentioned 7 work streams. What would be really helpful would be to keep this committee updated and reassured by way of giving us the detailed progress on those 7 work streams on a periodic basis, so that we can monitor genuine, tangible progress that is being made. And we talked about in your various replies, various targets and various pieces of work. It would be good to have that thrown into that update, so that we can see visible progress being made.
Be happy to come back here maybe in 6 months' time and give you a progress update against the 7 priorities.
Thank you very much. So, colleagues, before I bring this paper to close, are there any recommendations that you think would be helpful to make? Nick, please.
Just to reiterate the point you made, Chair, about once you have a better understanding of the government's new position on immigration, how this might affect recruitment and workforce within North West London would be really useful.
Thank you. Claire, you wanted to come in.
Very briefly, I just wanted to say a huge thank you, Chair, to you and to the committee. I personally found the discussion here hugely stimulating and helpful, reinforcing of what we're doing, but with some good additional suggestions. And I wanted to make an offer. I chair the Workforce Board, Nina and Kevin as the 2 CPO, Chief People Officer leads, attend that, as do the other Chief People Officers and other staff from across the sector. I would like to make an open invitation, actually, to any colleague on these calls to visit once, to come and visit part of the board, to, if we share with you specific agenda items, to dip in. I think we should be really open and inclusive about this work, because it will be the difference between our colleagues, our staff are the difference between us being able to deliver on our ambition for patients and a vision that sits on a shelf. So honestly, I'd like us to be really open, because I found the comments and inputs today hugely helpful and encouraging.
Thank you very much for that very generous offer, Claire. Any other point before I bring this paper to close? Natalia, please.
Thank you very much. So in addition to your request in terms of the update, I would definitely welcome an update on the Race and Equality Steering Group and some of those findings. Thank you very much.
Thank you very much indeed. Grateful to everybody's contribution. I'm going to swiftly move us forward, looking at my clock. The next paper is Northwest London winter pressure, and we have our colleague to present this paper jointly with Rob and Daniel in the room this morning. Rob, and then Daniel. I don't know who's going to go first from both of you.
So, well, I'll just introduce Daniel. So obviously, as part of our overall winter resilience plan, the work with London Ambulance Service and the acknowledgement that the work of London Ambulance Service cuts across how we are performing and how we're responding in our hospitals and other parts of community services and local services. So Daniel will take us through the London Ambulance Service perspective on that, but I just wanted to intro that in the context.
Great. And Daniel, of course, is no stranger to this committee, but I think perhaps, if I'm not mistaken, joining us for the first time in person. So really good to have you in person. Thank you very much.
I couldn't resist coming back to Hounslow. It's been a long time since I worked here. So I thought I'd give you some words that back up all the numbers that are in the reports, because we seem to have given you rather a lot of numbers. So in terms of some headlines from London Ambulance, we've got more staff than we have ever had. We've been on a massive recruitment spree for both call handling and paramedics. We've built 2 state-of-the-art training centres, one of which is in Hounslow in Brentford. And if you want to see paramedic training in action with a simulation centre and all sorts of things, you would be more than welcome to come. We've introduced a completely different way of working in the ambulance sector. So I used to run a hospital like Pippa does, and team working is a big thing in hospitals. Team working in the ambulance sector has never existed. So we've got everyone now working in teams. The result of that is our staff engagement is massive. So in the staff survey that's just completed, we're up to almost 70% of people actually filled in the staff survey, that's about 6,500 people. It's way more than before. And then also paramedics have never been able to get any feedback about how good their care was, because the data in an ambulance service has never been linked to the rest of the NHS. So with Rob's help in Northwest London, by Christmas, every paramedic will have an app on their iPad like this, where they can look up what patients did I care for yesterday and what happened to them when they went to Norfolk Park or Chelsea and Westminster, and if they got admitted, then what happened. And it will be a total game changer in enabling a whole clinical profession to actually do morbidity and mortality meetings that every other clinical profession has had for a long time. So I think that is going to make a really big difference in care. On performance category 1, so that's the very, very sickest patients. We're normally first or second in the country for that. To give you an idea of volume, that's like 450 to 550 patients a day in London. Heart attacks that are real proper heart attacks fall into Cat 1. And the thing that saves people's lives is getting a paramedic there very quickly, or getting someone who is trained in resuscitation there very quickly. So you can be pretty assured in London that if you phone 999 and it's Cat 1, within 45 seconds of us picking up the phone, we will have dispatched an ambulance, and nearly every time we'll be there within 7 minutes. But we're also making a big deal about how many Londoners can we train to be London lifesavers. And we've launched a new campaign about getting school children to learn how to do this. And we've picked 8 boroughs in London where the heart attack survival rates are the least good. 3 of them are in Northwest London. And we've got a team of people who are now approaching schools in Brent, Harrow and Ealing to say, can we come and train the first year of secondary school students how to do CPR? And we're already beginning to see the results of this. One of the things you asked for was return of spontaneous circulation. So can you survive a heart attack? And for the last month, which published after this, we've got to 31%, which will be nation beating in terms of survival rates from a heart attack. So that's very good. On category 2, so that's the vast majority of the patients. So we're, as you can see from the data, not achieving the standard we have been set. But when November data comes out next week, our performance in November this year compared to November last year will be 26 minutes better. That's a huge improvement and means we are definitely making better care. So that's down to having more people, which means we've got more ambulances. And if you look at this weekend compared to the same weekend last year, we had 40 more ambulances each day on the road. It's also down to much better handover processes and much reduced handover delays. And not wishing to make Pippa and her team blush, but the work that we've done in Northwick Park and Ealing has been completely transformational in the last year. And so where Northwick was a bit of an outlier for handover delays, we never talk about it anymore as a problem. So that is very good. And then category 3, so that's mostly frail elderly people who have fallen and people with mental health. We're normally first or second in the country at that. We think those are some of the most vulnerable groups of patients, and we do our absolute best to get there as quickly as possible and don't deprioritise them. And sometimes you see, touch wood, newspaper stories, the headlines of frail elderly people being left for hours and hours around the country. So far, there hasn't been one in London, and I'm very hopeful that we carry on like that. That's what I was going to say.
Thank you very much indeed. Grateful to you, Daniel, for joining us this morning in person. Grateful to you, as I say. Let me now take some questions, and let me bring Ben in first. Ben, good morning.
Thanks, Chair, and thanks, Rob and Daniel, for the report. I spotted that there's no reference to the Met Police decision about right care, right person and the knock-on effect of that. It'd be really helpful to understand the position, as there's been a reported 15% reduction in Met attendance at mental health instance, and it's unclear where that demand has moved to.
Thank you, Daniel. And perhaps Claire might want to come in here as well. Daniel, please.
So we planned very carefully with the Metropolitan Police for this change. So there basically has been quite a big shift of activity from the Metropolitan Police to the NHS. We're getting between 150 and 200 extra calls a day because of it. The way it works is that we've had a paramedic sitting in the Metropolitan Police control room to ensure that their call handlers were asking the right questions. We made sure the script that the police control people were asking was very helpful to us. We've been insistent that any referral that comes from the police to us has to come with the name of the person and their telephone number, so we can actually contact them. Most of our communication is electronic by email. And we've then assembled a team in our control room, which is made up of both 999 call handlers and 111 call handlers. And that's a big advantage of us being now having a 111 contract everywhere in London. And we've been sifting through the referrals and deciding which person would best go through the 111 system and which person would best go through the 9 system. Nearly everybody is actually a 111 would benefit from 111. And we have managed to manage this extra demand with the resources we currently have. Clearly, our 111 activity has gone up, but we are not sending lots of ambulances to lots of people who don't need them. And we have a real-time process with the police that if one of our crews says they're feeling at risk because they're going to see someone who is violent, the police will absolutely go there, no questions asked. As of today, we have had no incidents where either the police have thought we should be there or we thought the police should be there that we haven't resolved in real time. So I actually think this is a success story of implementing something, and the people are getting better care. But there is clearly a cost shift from the police to the NHS as a result. And that's big. And then before Claire comes in, they're going to make another big change in this spring where currently the police are taking a lot of patients to hospital who are sectioned. And in reality, that is an ambulance service responsibility. It's just that the police haven't done it. We haven't done it for years. The police have been doing it, and they're saying they should stop. That is totally right. So we've received the capital for having 13 mental health dedicated ambulances, which will be here in the spring. And then I need to look to this nice chap here to work out how we're going to staff them. But that will be a better experience for those people because they're actually then patients and should be conveyed by the NHS, not by the police. But that's a big cost to worry about, but that will be better.
Thank you for that. Let me bring very briefly Claire in. Claire, thank you.
Yes, obviously. Thank you very much. I'm also leading nationally on this issue, but in my trust world and very much monitoring the situation closely. I think that at some point this committee may want an update on RCRP, right care, right person, in its own right, because it does, as Daniel has suggested, affect it could affect fire services, ambulance services, the acute trust, social care and mental health providers. So it will have a big impact. It's about trying to do the right thing for people, using the right resource. I think nationally, we're really keen though to understand what the resource implications are and to make sure they're properly funded. And also there are cohorts of people who don't fit neatly anywhere that Daniel was alluding to, welfare checks, who might not be part of any service currently or need a 999 response, but may be really vulnerable.
Thank-
And so ministers and police chiefs nationally have agreed to work with partners to look at those people and how we keep them safe. An example would be a sister calling from London to say, my brother hasn't been in touch for 2 weeks, he's lost his job, we're really worried about him. Whose responsibility is it in those situations to check? So there is more work to be done, but thus far, really careful monitoring and leaning by colleagues in London means that it's going relatively well.
Great, thank you very much. Very briefly, and if you particularly want to reference the point that Daniel was making towards the end, and I think Claire also alluded to it in her reply as well.
So fundamentally, this has gone because of the planning better than our worst fears of what would happen. And indeed, there are some indications this is the right thing to have done and an improvement in service. Where that is demonstrated and money needs to flow to the appropriate service model, the ICB is here to assist in refereeing that. That's what we're here to do.
Thank you for that reassurance. Grateful to you, Rob. Let me bring Chetna in. Chetna, thank you.
Thanks very much. Daniel, it's very good news to hear what you've just said about the mental health change with the police being transferred over to the NHS, rightly so. However, in terms of the winter context, there's a line that says, this is an ongoing, it's a major focus during, especially during winter, discharging patients from hospital beds. How do you plan on sort of combating that in the short term until the spring and that really rolls over? And secondly, in terms of the estimated risk for industrial action, or are you able to meet the national targets for the delivery of urgent and emergency care over this winter? And will the described mitigations fully offset the impact of industrial actions during this winter? Thank you.
2 big points. Thank you.
Probably more appropriate for me to take that. So discharges, UEC and industrial action. So yes, we have had 2 really tough winters. We've tried to learn out of last winter because a lot of the challenges that Daniel faced arise as a result of backdoor issues in our hospitals. And we do, as we speak, have at any one time 650 patients in our acute hospitals not meeting the criteria to reside. And we estimate that we can and should be making an improvement of 100 to that figure over the course of the winter, which is why we've introduced bridging services, which invested in additional beds, invested in additional virtual ward capacity, which represents about 500 beds. The physical beds, 178 extra over the winter. The discharge hubs now up and running in all of our boroughs and seeing the green shoots of improvement in reductions in patients not being in the right place and the numbers coming down, and indeed a focus around the community and mental health delayed discharges as well. So that's a daily process over the winter, and we will again learn this winter and invest our funds into the most impactful initiatives in partnership with local authorities around discharges. On our UEC national targets, we are one of the few integrated care in North West London in the whole country that has committed to meeting its, to continuing to stay on track with our key urgent and emergency care targets, notably the 76% 4-hour waits in A&E, which we are not at the moment. We still have the aspiration to get to that, and the category 2 average for 30-minute target, for which, as Daniel's alluded to, we're unlikely to get to that target, but we have made significant improvements relative to where we were previously. As a result of the additional 37.1 or 38.1 million industrial action funding that we've received, we have used that entirely to mitigate the impact of industrial action. We haven't had to stop any of our investment and in performance improvement in order to hit our financial targets for the year. So that has been entirely targeted at keeping our plans on track that we had and using that for the impact of the reduced activity that we had as a result of industrial action.
Thank you very much indeed for that. Let me bring Marina, please. Marina.
Thank you, Chair. This question's for you, Rob, I believe. How many of the 630 virtual beds are in Hounslow, and are we able to get a breakdown of virtual beds by borough? And do we have a sense of their effectiveness yet?
Thank you.
I haven't got the numbers in front of me by borough, but I would have to go away and provide that information separately. We're currently at about 330 of our 500 overall virtual ward beds. And that level of utilisation, again, and growth in actual usage of virtual wards is leading one of the leading geographies in the country. But I apologise, I don't have the Hounslow specific data, but I can get the team to break that down.
Pippa, please.
Well, we can break it down by borough, but broken down by hospital, West Mid is actually one of the best performing at virtual wards. So they've been doing the cardiac pathways for some time now, the heart failure pathway for some time. It's very well embedded, and the majority of that is Hounslow patients. So we can certainly get you that data. It's hospital data. We can break it down by borough.
Thank you very much for that. Thank you, Marina. Lucy, please.
There we go. I also want to welcome this paper and the work that's been done, as clearly there's been some great changes over the past year. Just want to talk about general and acute bed plans. As Rob, I think on the 12th of September in our meeting, you said that your target bed capacity was 92% going into winter pressures, when it's recommended that hospitals work most safely and effectively at a bed capacity of no higher than 85%. Looking at page 29, figure 2, and your general and acute bed plan, is there a case for increasing bed capacity so we are not faced with periods of having to step up beds quickly? And so, to put it more bluntly, do we have enough beds in North West London?
Thank you.
To put it bluntly, we have enough beds in North West London. We don't use them effectively as we should, and I've described the discharges issues that we face. And so we have invested in additional acute bedded capacity in a context where we have significant opportunity to not for people not being in the right setting for their needs and their care. So our strategy ultimately is to improve, is to get patients and residents to the right care setting, as opposed to open up more and more acute beds and having care in an inappropriate setting.
Thank you. Lucy?
Thank you for that. In that sort of those different percentages of 85% and 92%, are we still aspiring to those figures, or is that just not? That's just something I wanted to clarify.
So I think we yes is the simple answer. We follow best practice in terms of what utilisation. The reality is we've got a balance to strike here about the reality of pressures day to day, the impact of the things that we're bringing online to improve the situation, and the time that it takes to get those fully up and running. And we do, I mean, we had other examples of community and P2 rehabilitation facilities not being fully utilised. We're commissioning all sorts of services where the utilisation was well below 85%, and those have been coming up. So we're showing that in areas where we had underutilised, we've improved that. In areas where we had over inappropriately unsafe high utilisation, we're in the more of the sort of ballpark range of safety. More to do on getting to the ideal range around that.
Thank you very much for that. Thank you. Let me bring our colleague Consia who's on screen. Consia, please.
Thank you. Just before I ask my question, I just want to say thank you for that encouraging report around heart attacks and the work that's being done. I can see that being really useful, especially so with young people as they become more embedded in the system and understand the way that things work, and the impact that that would then create in the long term would be really good to see. And hopefully we've got monitoring in place to look at that in years to come to see where that takes us.
And Consa, I don't know if you can see on your screen, but the analyst nodding his head in affirmative. So another positive sign. Thank you.
That's great. Thank you. No, I can't see, so thank you for that. My question is a really short one, really, and it's just around medicines and the issue that we know we faced previously on page 33 around winter pressures and what that does. What's the plan really in terms of increasing medicines just to ensure that there's no risk to patients?
Thank you. Who's going to pick that up for me? Pippa?
Yeah, so we've planned our hospitals for the winter. So we've planned actually at a 96% capacity. That means we plan for the number of blood tests we need to do, the number of diagnostic tests, the number of equipment, and including medicines that we need. So we don't yet, and most of our medicine shortages weren't because we didn't have them. There were supply chain issues on the back of COVID, and we actually have risen over that. So we don't have any major supply chain issues of any of the medications that we're using, and we certainly don't have any shortages, and we've planned for the capacity that we'll be delivering over winter.
Thank you very much for that. Daniel, let me just pick up one or two small points, if I may phrase it as such, before we move forward to the next item. You referenced category 2 and category 3. So and of course we don't have the up-to-date figures, which are going to be releasing shortly. But I want to understand category 2. Obviously, it's good news from what you're saying, but it does feel like that it is still high. And I want to understand what tangible stuff that you are doing actively in a sense that we can get even much more assurance, please.
So at one level, running an ambulance trust is rather simpler than running a hospital, because in the end, I'm only doing one thing. I'm answering the phone and I'm sending a response to somebody. So there are 3 variables about getting a response to somebody. So it's how many people call and how many, and then how many people you want to send a response to. It's how many ambulances or other vehicles do you have, and then how long does it take to treat somebody and take them to hospital or discharge them. So on the how long is it taking, so handover delays in London, they're way higher than they should be, but relative to the rest of the country, they're very low. So there's less to go at in the can you make things take less long. So the 2 variables you get left with are, can you have more ambulances? And I think our modelling suggests that we've done very well at increasing our capacity this year. But if we're going to meet the current level of demand, we need to do exactly the same again next year. So we can recruit all the people, so people want to come and work for us. That is really very good. There's a lot of conversations we need to have about, can we afford to do that and can we get the money? So one part is more people. And then the first bit is, can there be less people that we need to go to? And what is clear to all of us is that lots of people who are phoning 999, if we can do an alternative to an ambulance, there are many alternatives that would be better. So that involves having senior clinicians to do is called hear and treat, so telephone assessment or online consultations. It's making much better access directly into urgent community response, urgent mental health response, going directly to the thing called SDEC. So that's taking people to Pippa's hospital that isn't A&E, but directly to the right specialist. So there's lots of stuff that we can do to reduce demand, have more people, and we can go a little bit further about making it take less long.
Very, very briefly, Rob.
Just to briefly say, because as Daniel says, this is a system-wide issue, and underneath what he's talked about in London, there are differential issues in almost every borough. But just to highlight the importance of primary care and same-day access routes, and we're working very closely with Daniel and the team, in particularly in looking at a standardised model for same-day access into primary care, so that we've got the unnecessary demand and deviations, of course, so that we get the right people down the right track. But so that's an important component to this.
Thank you for that. Pippa.
And just to add to all of that, I think we've all got a responsibility to keep re-educating the population. So I did.
But that is the point that I'm coming to, and I'm going to bring Rob and Rory in about the communication plan. So you're stolen my thunder.
My reflection, I did a session on Brent Radio last week around how people can prepare themselves best personally for winter. The 2 most common questions we got is, if I call an ambulance, will I be seen quicker in A&E? I said, no, we quite often get people from a trolley and sit them in a waiting room, and most paramedics won't bring you to hospital. But that is a myth that people think if they call an ambulance, they'll be seen quicker. And the second most common question was, will I be seen quicker if I come to urgent care centre than waiting for a GP appointment? And my answer was no. But that is, I think, the belief of some of the population right now. Because of healthcare over the last 3 years, we have provided a different model of healthcare because we had to. We need to start re-educating around pharmacists, GPs. GPs are not just working 9 to 5. We've got a lot to do to educate our population.
So talking about that, let me just then continue, Daniel and Rory. What particular communication plans are you undertaking, which is perhaps somewhat different from what we've done in the past? And Rory may want to come in, but let me bring Rob in first.
Yeah, so just got to be clear that we do invest significant money in communication plans. We really try and do that in partnership with local borough, but it's local. It needs to be hyper local. It needs to acknowledge local variation and local communities and hearing message. But I'll let Rory give the headlines.
Thank you, Rob. Rory, please.
Yeah, I really have to. So what we are working, as Rob says, very closely with local authorities and with your local authority comms teams, and it really is a joint plan also with our provider trust right across the across North West London LAS as well. A big part of that is targeted engagement with specific communities. So we're funding 34 community groups, the grassroots groups, go out and talk to people and take some of the messaging. People that we wouldn't necessarily always reach, but people who these community groups know and who are trusted sources of information for them. So that's a big part of it. There's obviously a big social media campaign, which we do every year, but a lot of that is targeted advertising as well. So we can target, for example, LSOAs and areas where vaccination uptake is low. So we target those areas with specific adverts. There's also this year, for the first time, we're trying Spotify advertising, which is a new one, which we're told can have a really good reach. And the other thing we have is Google advertising, where if somebody in North West London clicks searches, say, for emergency care or urgent care or a number of different terms like that.
Great, thank you.
1118. So yeah, and obviously, media work and things as well.
Great, thank you. Thank you very much for that, Rory, and good to have you joining us this morning. Finally, very, very briefly, 10 seconds, 20 seconds, Daniel. Category 3. You said those individuals were the important cohort, and looking at the figures, looking at the statistics. So obviously, the last statistic that we have is somewhat out of sync. If you look at it, if you look at the data from earlier this year, January. And I know the most up-to-date data is not released, but what are the early signals? Is it going to go in the right direction, or do you see it going up just like last month?
Well, as we're going to the winter, all of the response times are going to go up because demand is huge. But I suppose our mission in London is to say we don't actually think the Cat 3 patients are less sick than the Cat 2 patients. So we are broadly trying to keep the response times the same. But the response to a lot of the Cat 3 patients isn't an ambulance. So we've got 8 cars with a community nurse and a paramedic to go to frail elderly around London. And I'm hoping we're going to have one in North West London very soon. We've got 6 cars which are a paramedic with a mental health nurse to go to mental health patients. We have got a massive program of upskilling paramedics to make them advanced practitioners, and they can go solo. We've just got e-bikes to go so that the what was just in central London, the bikes can now go further too. They're very good at getting to the Cat 3 patients. So I think overall,
great,
relatively.
Thank you.
One last stat to give you. On any day in London currently, 13,000 people are phoning 999 and 111. It's a totally massive number. And in going back to the thing about the comms, nearly every one of those patients does have an urgent or an emergency healthcare need. And now we have the 111 contract in all 5 ICSs. We have now started, if you phone the wrong number, whether it's the 9s or the 1s, rather than telling the person to phone back, we're just transferring the person to the right telephone number. And that is actually going to make life way better for them.
Thank you very much indeed. Thank you. Any recommendations that we see? Yes, Ben.
Just picking up on Claire's helpful offer about a briefing paper on the right care, right person. It'd be really helpful if we could have that, focusing on impact on partners, but also the changes that Daniel mentioned were coming in the spring. And just on the comms piece, I did check in with our Director of Adult Social Services prior to the meeting, and his view was there's more that could be done with local authorities. So I would recommend some further outreach work with the local authorities comms teams.
Great. I can see both Rob and Daniel agreeing. Thank you very much. Anything else, colleagues? Thank you very much. So we will move to the next paper. Thank you very much to you, Daniel, for joining us. Okay, so the next paper is Northwest London Elective Orthopedic Service. And we have Pippa Nightingale and Mark Titcombe with us this morning. I think, Mark, you're joining us for the first time. Very welcome. Good to have your company. And of course, we still have Rob remaining for the other items that we have. And thank you for remaining behind, Rob. So, Pippa, over to you, and then we'll bring Mark in as well.
Thank you. So it's great to be back talking about the Elective Orthopaedic Centre, especially as we operated on our first patients yesterday. So we went live with the date that we'd set. Very successful, smooth start. The patient was actually an Imperial patient from Hammersmith and Fulham that was operated on yesterday, had a new knee, and went home on the same day. So it couldn't have been a smoother start. So I'll take the glory and let Mark, who's done all the hard work, go through the presentation.
Thank you. Good news and congratulations. And it seems like the all went well yesterday. Very pleased indeed. Mark, please.
Thanks very much. Yeah, I'll just build on a couple of points and build on the report that you've got. Just in terms of to give probably a sense really for this week. So we've got around about 46 patients going through the EOC this week. We'll be just under 200 going through in December in total. Once we get up to full capability, and you'll see from the report that that's due at the end of February, beginning of March, when we get the additional 2 theatres, we should be seeing between 400 and 500 patients a month, and that will take us through to the 5,000, between 5,000 and 6,000 expected each year. So I'm very much on track in terms of that, and delighted, as Pippa says, to have opened yesterday as scheduled. A couple of points just to add. We've been really conscious that we wanted to build on the involvement of residents and the public, which was established particularly during the public consultation at the beginning of this year, where, as you know, just under 2,000 residents contributed to that. And that particular focus around making sure that we got the transport provision correct for the Elective Orthopaedic Centre was a real focus. We held a webinar with around about, we offered it out to about 200 of those 2,000 who said that they were interested in contributing some more. And from that, we then developed a transport working group, which has sat a number of times throughout the summer. And that's comprised a councillor from Hillingdon and a number of residents from across the 8 boroughs. And what we've done effectively is design the transport solution in parallel with the residents to make sure that what we're providing is really what patients and residents would want. And there's some detail of that within the report. One element that came through very strongly was the importance of the human touch in terms of making sure that patients, their families and carers coming to the Elective Orthopaedic Centre had actually a personal contact. And so what we've developed within that transport solution are a number of patient pathway navigators. There's going to be 4 of them in total. We've got 2 in place at the moment and another 2 joining. And as well as providing all the online and telephone material, they're based at Central Middlesex, and they're able to interact with patients while they're there. It's a 7-day service. And they're also able to meet family and carers at Central Middlesex and provide some of the advice around transport in particular. And you'll also see within that we've made sure that we've covered for those patients that have got complex, long or costly journeys, we're able to provide that transport to really overcome that concern. And I think it's just worth saying, actually, one of our schedulers was talking to a patient last week who's due to come into the Elective Orthopaedic Centre. And one of their concerns was the fact that it was a particularly lengthy journey. And in that case, the scheduler was able to reassure that patient, and that patient's now due to come in December. So I think there's a little bit of evidence that we're beginning to get that working in practice. And the final point, just to add to the report, was really about the the capacity and the system that the elective orthopaedic centre will offer us. So when we get to the full capability at the beginning of March, as we know, that's 5 theatres. So that's additional capacity for the elective orthopaedic centre, where most of the routine hips, knees, and some upper limb work will be done. But crucially, of course, it frees up capacity within the home trusts for some of the perhaps more complex orthopaedic work, or indeed other elective operations. So we'll help contribute to that overall elective recovery. And some of those more complex patients are, of course, the long waiters. So there's that additional benefit of freeing up that space and being able to progress some of those long waiting patients in particular.
Thank you very much for that, Pippa and Mark. So Mark, you now know the drill. There'll be some questions. And let me start with my colleague Chetna first.
Thanks very much, Mark. First question.
Microphone. Sorry, thank you.
Thanks, Mark. Do you foresee any challenges going forwards from now until March that maybe, could be looked at again? I don't know what makes me ask that. Something makes me ask that. And also, could you elaborate on the mechanisms that have been established for ongoing monitoring of the new orthopedic centre, and also specifically producing intended improvements, productivity, quality, which is quantitative and qualitative, and efficiency that led to the centre being developed?
Great, thank you for that. So on page 44, Mark, so we have a reference being made, I think it's page 44, on our papers, a reference being made about ongoing monitoring. So I think that is what Chetna is perhaps alluding to, and it would be really good to understand what that looks like, so that we have some sense of assurance. Thank you.
Thank you. Yeah, 2 points. In terms of I'll just start with the challenges between now and March. I think we're continually, keeping a really close eye on the programme to make sure that we keep it on track. One of the areas that we're particularly focused on is making sure that we've got the right workforce and the right people, and we've commented on that within the report. We've currently got about between 86 and 90 of the 140 people that we need for March. So we're well on track at the moment. And what we're finding is that the approach that we're taking in Central Middlesex Hospital is actually quite an attractive location and quite an attractive role for a number of people. It's that routine, fairly set procedure that is attractive. So we've made a really good start on that, but that is one area that I'd say we'll continue to watch. And within that, there are a couple of hotspot areas which I've mentioned within the report. In terms of the ongoing monitoring, it's a really, really key part. And as part of the planning and as part of the business case, you may remember that there was quite a comprehensive sort of benefits realization plan, but effectively the outcomes that we expect for our patients, both in terms of the qualitative ones around patient experience, around the level of engagement, around the way that they are clinically cared for within the hospital and within the elective orthopaedic centre, but also the quantitative ones about productivity, particularly around areas such as length of stay, for example, within the hospital. And we heard a little bit from Pippa earlier on in terms of that. So as we move from where we are now through to March and then on, we will continue to monitor all of those metrics, all of those measures, and make sure, particularly on the qualitative ones, so the patient experience, the patient engagement, that we involve the patients in those committees, in those processes that we've got. So we've referred in the report to the patient engagement committee, for example, that currently exists at Central Middlesex Hospital. And we'll make sure that that absolutely includes the elective orthopaedic patients as well. So we've got that sort of real-time feedback from our patients and from our residents.
Yes, Pippa.
Just to come on the back of that, I mean, it's absolutely the right question. So looking at productivity, we have got a huge challenge on our hands. We didn't do this for the fun of it. We did it because we know, looking across the country, this model is the most effective way of delivering as much activity as you possibly can. However, what we know at the moment is most surgeons are used to doing, let's say, 3 knee replacements on a list, and we've said they've got to do 4. We haven't done that yet. They've started off with 3 yesterday. So Mark's got a big push to do along with his medical director to say, okay, this is great, but this is what we signed up to. So it's a different way of working for them. And the whole idea is you simplify a pathway, you're just doing the operations, you've got no distractions from emergency surgery, you can get more done. But that's a mindset change as well. So we have got a huge way to go to fully deliver the targets that we've set, and that is what we're sticking to delivering.
And you hope, Pippa and Mark, to have the service fully running by February, March. I think you say in the paper somewhere 5 theatres, which you just referenced as well. And we talked about, Pippa, I think you may have slightly missed the early part of our conversation around workforce. And we started off this morning session with workforce. And I'm keen to understand that particular challenge is going to be navigated by the time we come to February, March, April time.
Yeah, so February, March is when Hillingdon Hospital come on board as well. We've got two new theatres, so the 2 brand new theatres that are currently being built now will be finished. Hillingdon come on board, and that's the completed picture. Workforce is interesting because actually what this model shows us is what we thought, but you can never see it until you do it. These models attract people into Northwest London. So having a different way of working, having a bespoke model, having something that people are interested in. We haven't just done a bland campaign for come and work with us. We did a unique campaign on the Elective Orthopaedic Centre. Therefore, we're a net gainer of workforce. We have brought people into Northwest London. And what we haven't done, which is what we've worried about, we haven't poached from other trusts around us. They've chosen to come over. They can come and do some lists with us, but we haven't taken from Imperial, Chelsea or Hillingdon. We've brought people in from other parts of London and wider, actually. So we need to learn from that in terms of these models are attractive to our staff. This is how staff want to work, and that's
Great.
a positive thing.
Thank you very much. Natalia, please.
Thank you very much, and it's good to hear that it's now open and operating. So, in operation. So, for the patients that you've alluded to that have started, have been seen this week. So, what specific systems are there in place to engage them in terms of this initial experience? So, you've mentioned understanding that their patient experience, but can you please give us more specific information as to how is that captured? Also, for patients who may not have English as a first language, what systems are there in place to capture their feedback, please?
And I think you showed us when we came to visit, and I think one of your colleagues did mention about the language and the work that is being supportive. So it's good to understand, how that is being scaled.
Yes, we've done a few things. So first of all, the normal collection of patient experience, that happens for all patients, and then we can break it down by specialty. So we'll be able to see which patients had their care at the Elective Orthopaedic Centre, what the friends and family score is. That's only a small little touch base. What we're doing for the first few patients is really getting some detailed feedback, so some face-to-face feedback. I mean, last night's story is a corker. I mean, he wanted to go home so he can get to his pub quiz tonight. You can imagine the story that will tell. It couldn't have been a better patient, if I'm honest. But, it's really important to actually get some more detailed feedback at the start so we can understand what the challenges were, what went well, what didn't go as well, so we can then start to use that to adapt. So we're doing more detailed feedback on the first few patients that come through so we can use that to adapt care.
Thank you very much indeed for that. Mark, did you want to? Sorry.
I was only going to add actually that when we very much involve sort of patients and residents in the development of the sort of signage around the hospital as well. So doing that sort of walk around with patients and with residents, we've been able to make sure the signage is there. It's in several languages as well to make sure that we've covered off that. Plus I mentioned earlier on the sort of patient navigators effectively, or support staff, if you like, who are able to interact with the patients directly. They're going to be really crucial during the early stages to make sure that we get that feedback exactly as Cliff
Thank
said.
you very much for that. Constance, please. Thank you.
Yes, thank you. When will the first report to understanding the changes to different levels of care that are being introduced and overall clinical outcomes for patients be considered? Has a time frame for this been worked out?
Thank you. Mark?
Yes, it has, is the answer. We've got we have a monthly partnership board which comprises all the 4 acute partners for the Elective Orthopaedic Centre. That has been sitting every month, but it will begin to look at the initial data from December when it meets at the end of January. and every month thereafter, and it will be effectively have a dashboard of both clinical, quantitative, qualitative patient experience results to look at. So from the end of January onwards, that will be being looked at. Of course, within that, on a weekly basis and indeed on a daily basis, we have the medical director, we have myself, just making sure that on that regular basis we're able to do that. But the formal reporting will begin at the end of January through the partnership board.
Thank you. Rob, please.
So just to note, in the context of everything, I mean, this is a fantastic example of implementing good practice, getting the balance between scaling something for the benefit of patients with the important work of involving residents on the travel constraint. I think if we can't do it in orthopedics, good luck to us in everything else, is what I would say. This is a lesson for the future of orthopedics. You can measure things. We have things called patient-related outcome measures. We have something called a national joint registry. You can look up online what patients are actually saying and how individual hips and knee joints are, how effective they are. There's a wealth of information. So, commend the team for that. But I think the wider point is the best use of resources for best outcomes for patients that meets the workforce requirement is a lesson for many other services that we will be going on a journey in the coming years. Thank you.
Thank you very much. Constance, do you want to come back with a supplementary very, very briefly?
No, that was great.
Thank you. Thank you very much. Let me bring Ben in, please. Ben?
Just want to say congratulations on the first procedure yesterday. I appreciate there's still a long way to go, but also wanted to pay tribute particularly for the work that you've done around transport. We often talk about kind of co-production within the NHS, and I think this is a really good example of including patients on that journey. The report mentions about reviewing the situation on an ongoing basis, and it'd just be helpful to have that detail of those reviews in due course.
Thank you very much. Very, very briefly, Mark.
Only to say that I think within that transport group, we've developed a real rapport actually with that group, and we want to build on that. So rather than just saying, right, the transport piece is done, we want to now effectively move that into the patient experience, patient feedback, and how is the transport looking.
And if you could keep us, updated, it'd be really helpful. Thank you. Maureen, please.
Thank you, Chair. This is a transport question also. Are you able to provide clarification on what criteria are considered for defining journey times as costly, complex or lengthy, making patients eligible for the free transport services? And are you able to confirm that this will be delivered through ambulance services and not contracts with taxi companies?
Thank you very much, Marina, for that.
Yeah, so what we've got is effectively at Central Middlesex now for the elective orthopaedic centre. We have a dedicated, effectively a ring-fenced transport facility. Of course, it doesn't have emergency care at Central Middlesex, which is a huge advantage. So there's no risk of that transport being taken off for a higher priority. And we've made sure that we've got sufficient of that, and it is ambulances or car ambulances for our patients, so that we can get them in early in the morning when we need to, and we can get them home in the evening or indeed at weekends. And we are expecting to discharge throughout the whole of the weekends. In terms of the first point around long, complex and costly, we've got established criteria on that, but effectively we're taking, we're trying to be as open and as helpful as possible, not just for patients, but for their carers as well. Now, we can't extend that all the way to family and friends, as you'll recognise, but we're being really sort of open and transparent around that.
Thank you very much for that, Marina and Mark. Let me bring Lucy in, please, and that will be the final question.
Thank you, and this is another one on transport. I just wanted to check if the plan you'd put in action includes the healthcare travel cost scheme to provide financial support to those who qualify for benefits. And within the guidelines of the scheme, it says one of the specifications is to have a referral for specialist care, which I presume would be what this appointment would be categorised as.
Thank you for that. Yes, I can confirm that. It does include the healthcare travel scheme, yes.
Great, thanks.
Thank you very much. Any final point? Thank you very much. Any recommendations that we would like to make? Yes, Chetna, please.
Can we ask for a report to this committee on the success against metrics and targets identified for the orthopaedic centre? And also, can we get feedback from staff? It would be really interesting to get some reports from staff, like after March, how they feel things have been going, and maybe what we can improve, and actually what the NHS system can learn going forwards as well. Thank you.
And maybe you might want to just slightly broaden it to patient service, and it'd be interesting to find out. Obviously, yesterday was a very positive news, but overall, it would be good to find out what those emerging themes are, and where you are then going to be putting mitigating stuff to ensure that there is this positive outcome for everybody. Thank you very much. And we will now move forward to our final substantive paper. Sorry, Ben, I missed you. Sorry, Ben.
It was just, could that report include the detail that we mentioned on transport?
Thank you very much. Thank you. Pippa and Mark, thank you very much. And thank you to Rob as well for your contribution. So I'm going to move to our final paper, if that's okay. And we are slightly running behind. So a very, very quick a minute or two, and then we'll go straight into questions, if that's okay, Rob.
Thank you. I'm in your hands and what you want to focus on. This is really a mop-up report of some various ongoing themes in the background.
Thank you.
After your advice on how you would like some of the future communications, what information you want around these particular strands. Obviously, just to draw out, when I'm talking about the NHS North West London Integrated Care Board Organisational Design Programme, I'm talking about the core staff that are employed, that are funded under a National Health Service running cost allowance, which is being reduced in order to reinvest £12 million in frontline services. That's going to lead to a significant staff reduction of the order of 100 staff out of the 900 that are currently employed. About 3 years ago, that was 1,100 people. So we're on a continued trajectory to reduce the overhead running management costs in order for that money to be reinvested in frontline care.
Thank you very much for that. Grateful to you. So, but let me bring my friend Consia in, please. Consia, with your first question then.
Yes, thank you. This is a question around palliative care. Where are the community specialist inpatient beds and palliative care services for adults located in the Westminster Council? And how many are there? And how will the decision be taken when someone is placed out of borough away from their family? And supplementary to all of that, I want to look specifically at Pembridge and where things have gotten to with that.
Thank you very much for that, Consia. Rob, please.
Yeah, so clearly this is at a pre-engagement stage. We're nowhere near a consultation on this process. The engagement needs to establish the options around Pembridge for the future. And that very much it is part of the rationale for this process, which has already been going for some time and will continue to go through engaging with all the stakeholders, including within Westminster, on the future of Pembridge. Today was just a signal that is ongoing work rather than this is any part of the sort of reaching anywhere near a formal consultation process. We're very much a pre-engagement on all of these schemes, and the Westminster impact is summarised in the slides, but I'm happy, I realise that will be a feature of the future engagement and consultation process around the impact on Pembridge.
Okay, thank you very much. Constance, did you want to have another supplementary?
Yeah, just particularly on that last point around timescales, as we are so far away from looking at what things might look like and the interim measures around that.
Thank you for that. So those 2 points, timeline and interim.
On the timeline, I mean, we're looking at least another 6 months of this engagement work before we're getting anywhere near a pre-consultation business case process. And
interim.
Yeah, so at the moment, current arrangements are not scheduled to change until that process unfolds.
Thank you very much for that, Rob and Consia. Grateful to you both. Ben, please.
Thank you, Chair. The plans for the 30% reduction in expenditure for the ICS haven't been shared in any detail with local authorities. There is a perception that there'll be variation in terms of the impact on local teams across North West London, with up to a 40% reduction for some borough-based partnerships. The balance between centralisation and localisation of staff is key in terms of how the borough-based partnerships and place-based working is applied, and understanding what the centralised functions will be as key in understanding what the remaining borough-based partnership function will be. I just wonder if Rob could comment on that.
Thank you, Gwen. Rob, please.
Very happy to. So we are this week launching an engagement document with partners, which will be coming out to borough-based partnerships and local authorities. As I say, within the overall timetable, we are now entering an engagement phase prior to next year, a consultation phase, next year being a transition year for implementation in full for April 25 of these changes. So we are still at an early stage of these proposals. Second point on, clearly so borough-based partnerships are a fundamental component of our operating model. We are not envisaging, we think there'll always be a London and we think there'll always be a London borough. There won't necessarily always be a Northwest London sub-regional unit, of which I'm currently the accountable officer. So the fidelity of upholding the borough-based partnership model out of where we came from with clinical commissioning groups into a future model of borough-based partnership, I can give you absolute assurances at the heart of what this is trying to do. Those borough-based partnerships are a generic term for the coming together of provider collaboratives, of local authorities, and indeed the people we're talking about here and now in this exercise for integrated care board staff, of which there are significant numbers in each of the borough-based partnership. When one is facing a significant reduction in one's operating costs, one has to use those resources to best effect to support the borough-based partnerships. And that means that we will be consolidating the support infrastructure. And that means that some of the staff currently working in borough-based partnerships will be consolidated so that the corporate infrastructure can be geared towards supporting borough-based partnerships to succeed. That is an inevitable consequence of reductions in running costs, because the alternative, which is to split the money we have 8 ways or on some population weighted basis, would mean the limited people and resources we've got would be stretched more thinly across those borough-based partnerships. A key element of the effectiveness of what we do is going to be the effectiveness of headquarter services. So the things, the digital, the work that we've described here today in terms of engagement, communication engagement, involvement, our statutory duty to support borough-based partnerships to do that. That means the coming together more in the future of those providers, those local authorities, and those integrated care board staff, rather than people like me coming along and saying we've got some headquarter function that's doing engagement. So we want to uphold those borough-based partnerships, and we want our central resources supporting those to succeed. That means our organisational effectiveness, so the things like how do we make decisions, how do we approve business cases, how do we employ people, all need to be more effective than they have been thus far. And so as well as this project is not about, this is called an organisational design, it is about making the integrated care board fit for purpose to support borough-based partnerships to succeed. We will organise ourselves, as we currently do, around better programmes of work that cut across the 8. So our programmes, rather than being centralised programmes, will be comprised and built up from the borough-based partnerships and the provider collaboratives and how they were operating. So whilst there is a headline that is we're disproportionately, in terms of ICB component part of our resources, disinvesting in boroughs versus HQ, I would describe it as an investment in the whole resources we've got in increasing the support to borough-based partnerships. But it will mean that as we engage with the borough-based partnerships, the ways of working of us to do that, and indeed the way local authority staff, provider collaborative staff, and ICB staff, of which there will be less in the future as an inevitable consequence of this, will need to work together differently. And the engagement process will be designed to go out and talk to people about how that might work in the future. And we've made no decisions about future structures until that engagement process completes over the weeks and months ahead, ready for a consultation next year, as I say, for full implementation in a transition year, April 24 through to full implementation, April 25.
Thank you very much. Thank you. Let me bring Nick in, please. Nick?
Yeah, no, thank you, Robin. And your assurance is very welcomed. And I just want to say I completely support the question that Ben asked. One of the things with the NHS is there's always seems to be a level of reorganisation going on all the time. I know that you're not responsible particularly for this reorganisation, even though you have to reorganisation, you have to deliver it. I suppose from my point of view, we spent 2 years getting into this new place with the ICB, ICS, all this sort of stuff. And to be honest, I think our borough-based partnership is working very well and very effective. And we're enjoying having honest, regular conversations between all the partners. And then suddenly we've got this new reorganisation coming in, which seems to have a significant impact on maybe how those borough-based partnerships might work. So from a personal level, it's slightly annoying that we seem to be now working well, and now we're going to have to change again. Now, I suppose my question or my point, which might be something more for when the consultation comes out, is from a local authority, what is the new borough-based partnership way of working going to look like in reality? Because I think that's, for me, is really important.
And also, Rob, is it going to be meaningful with such a reduction in number at borough level, at place level? How effective will it be going forward?
Well, the idea would be to hold on to that which is working and improve that which is not working effectively at the moment. And in the example you quote in Hillingdon, we'll be looking to build on the good work in that and making the HQ better at supporting that place-based partnership to succeed. As I say, there will be some conversations and through the engagement around whether the staff, the 40 staff, the ICB support that funds in the Hillingdon component of our overall 800 staff, how those staff are reconfigured so that we have a broader resource out of our 800 focused around supporting that. So it is a different model of support that we need to work through. It is frustrating that it's another change. It's been driven by circumstances beyond certainly my control in terms of a requirement to do this over this timescale. We do, because we are meeting our financial duties, have more time than other ICBs, and we have looked at what other ICSs are doing across the country to make sure that what we do is at a sensible pace. Obviously, we're facing the challenge of, as we generate these ideas and work with borough-based partnerships, we have staff going through anxious periods. So the pace at which we do it, mixed with the need to do it properly, has been uppermost in our thoughts, which is why I do, however, think we need to do it at the timetable I'm describing, rather than rushing through a staff cut of 30% with no notice.
Thank you very much for that, Rob. Let me bring Marina, please. Marina.
Thank you, Chair. Rob, one of the with the reduction of the ICB running costs, my question is there any way of the ICB getting out of its 10-year lease of the Marylebone Road office at all?
We are doing everything we can to get out of that lease, subcontract that, because, as you rightly point out, for every pound we spend on office and underutilized facilities, that is a pound that can be better spent in other ways. So it's mentioned in the paper, but the 2 million reduction in our office costs across our 8 different boroughs is part of this. And we very much see the Marylebone Road as an expensive, underutilized facility. I'm showing people around regularly to get that office paid for by somebody else until we can break the lease as soon as possible.
Thank you very much for that. Thank you. Let me bring Chetna in, please.
Thank you very much. Just want to say thanks for the refurbishments affecting the residents who use Belmont Health Centre in Harrow. My question is in relation to the estate strategy. London Borough of Harrow has recently produced a corporate estate strategy and is looking to develop a community buildings policy and leasing model to deliver for Harrow residents. Could you please confirm that you will be engaging with the council's estates team to ensure that there is an alignment on projects and residents' needs? And then I have a further recommendation at the end. Thank you.
Thank you.
Yes. So absolutely part of what we're trying to do in the estate strategy is make this beyond an NHS only and a health strategy. So the headline answer to that question is yes, and all models are on the table. One has to acknowledge, however, within that we do face some constraints in how we are funded and the models of estates that we are able to enter into in the NHS without sort of headquarters approval around some of those models, as PFI and other initiatives have shown over the years. We need to tread carefully in all of those models, but the basic concept of working together on making better use and having options for future estate configuration, absolutely.
Thank you very much. Thank you. Natalia, please.
Thank you, Chair, and thank you for the update. This is just going back to palliative care. You've made reference to this pre-engagement stage process, but from this initial stage, have lessons been learned in terms of communication and co-production that will inform the next step? Thank you.
I think, yes, in terms of the, and I think that's illustrated by the not rushing to the answer in this model. And I know there's been conversations for quite some time, and therefore the time scale that we're extending to make sure that that unfolds appropriately through engagement before we pull together any formal proposals for the future would be my headline answer to that. Pippa, do you want
to? Please, thank you.
So I did some work with this group at the start. So they are very much, this isn't just about beds. This is about understanding what good palliative care looks like for a population of North West London. And quite often when people end up in a hospice, it's not out of choice, or if they die in a hospital, it's not their chosen place of death. It's because we can't offer that service at home. So this is very much, we almost need to step back and learn from the lessons we made at the start, which was to look at our hospice beds. How many do we need and where can we close? Where should we open? Step back that step further and say, what does good palliative care look like, and what does that mean for our diverse population? Because dying and the way people choose to die is very different in different diverse populations, and we need to spend some time understanding that, because it might be very different even in boroughs, in them pockets of boroughs it might be different, and we need to understand then, if the majority of our patients' chosen place of death is at home, how do we provide that service at home to be able to support them to achieve that? Because currently less than 50% of our patients die in their chosen place of death, which isn't a good outcome. So this isn't just about beds. This is about really understanding the needs of our population and supporting patients to die well.
Thank you very much for that. Let me bring Marina, please. Marina, thank you.
Thank you, Chair. This is to do with palliative care as well. So in September, there was mention of providers working together closely on workforce issues for expanding our palliative care offer. Are you able to provide more details on the specific progress or developments that have occurred in this regard?
Thank you.
Yeah, so again, it's a really hard to recruit to role, and that's sometimes because we're not offering the right model of care. So, and it's also because this model of care is not largely the NHS. Most hospices are charity run, and therefore for a nurse to go and work in it, they lose their pension status because they're not working within the NHS. Hence why this is bigger than just beds. This needs to be, what's the right clinical model? Therefore, what's the right workforce model? And how do we attract people to work in this? Because my belief, when you listen to nurses, they really want to work in this way, but they're almost stopped from because of the having to leave the NHS to do it. And we need to create NHS pathways so we can provide good palliative care, and therefore use NHS staff to be able to deliver that care, as well as the voluntary sector that are huge in this area, and our hospices that have great expertise as well. So, but they're almost competing with us at the moment. So it is a bit of a wipe the map clean. What does the right clinical model look like? Therefore, the workforce model needs to be layered on top of that. And then what we understand is it will be much easier to recruit to them, because right now it's virtually impossible to recruit to a specialist palliative care nurse. We're all competing with each other to do that.
Thank you. Rob, did you want to come in?
No, I think you answered it better than I could.
Thank you. Marina, please.
Yeah, sorry. I think it's also, my background as well. So it's also good joined up working with providers as well, because they also provide palliative care to those at home as well.
Yeah, and we don't want to compete with any of that. We want to pull it all together. Actually, if you put it all together, we've got a great model, and the voluntary sector here are huge as well. So it's a complex model, but it should be a positive one, I think, if we get it right.
Thank you very much. Any final question from colleagues? Thank you very much. Any recommendations? Yes, Nick.
When we have more detailed plans of the redesign and the consultation, basically, if they could be discussed at this committee.
Thank you.
Because I think that how they impact all of us will be very important.
Thank you. And then Chetna.
Thank you. So really pleased to hear about borough-based partnerships. And what we're all most interested in is, can we get feedback on how it was, how it is now, what's working well, what can we do better, and perhaps getting reviews from patients and staff to get their feedback. Also, can we get feedback on palliative care and the further work you're going to do on people's chosen place of death? That would be really interesting for this committee to know, and how we can develop it. And also, Pippa, you mentioned about the NHS pathways for the NHS staff that you're developing. It'd be really good to see how you're developing that and how this committee can support you further. Thanks very much.
Thank you for those very helpful points. Grateful to you. Ben, please.
I just want to recommend that the committee supports the borough-based partnership and place-based working. It's something that is working rather effectively, as we've reflected in this conversation, and I think it should be formally noted.
Thank you very much indeed. Any other point? Any other final point? Thank you very much. Thank you, Rob, Pippa, for your contributions and your helpful replies to various points that were put to you by my colleagues. So we've finished with our substantive papers. We've got a couple of admin papers. So the first is the recommendation tracker. If there are any observations, very happy to take those observations. And then there ought to have been a item about our work program, but unfortunately that is missing. But we'll make sure that in future papers we do have that. So firstly, any observations on recommendation tracker? If not, then I suggest we note it as table, and obviously I will continue to monitor that. Yes, Ben.
There was just one item that I'd raised at the last meeting in relation to the North West London mental health strategy about engagement with directors of adult social services, and it says we're seeking clarification on this point. If any clarification is required, I'm happy to provide it.
Thank you very much. Thank you. We'll take that. I'll take that offline with Rob. Thank you. Are there any other observations? Okay, sorry, Consia, sorry, I missed your hand. Thank you, Nick.
Thank you. Really quick one. Just on the R's workforce and what consistency looks like throughout the boroughs, it would be helpful for us to pick that up at a later date.
Great point. Thank you very much. Thank you. Not missing any hands anywhere. Thank you very much. So the final item then is any other business. I'm not aware of any other business. But if there is, I'll take it very briefly. Otherwise, I will bring this meeting to close. Thank you very much. Thank you to all our officer colleagues from the local government and from the NHS for your support and your assistance this morning. And equally, thank you to all my committee colleagues for joining me this morning in this wonderful location. Marina, Harrow, thank you for hosting us. Thank you very much. Until next time, thank you very much. And I think it may be a little bit early, but I'm going to take this opportunity anyway of wishing you season's greetings. And I hope you have a very healthy and safe and relaxing season break. Thank you very much.